Hey, and welcome to another edition of Unfiltered Productions. This is a second one on value-based purchasing. And value-based purchasing is an interesting thing in home health that is possibly, I'll say probably, Cindy, that's a fair statement, going to be coming in 2022 to more states than it is currently. Um, Everybody thinks that that's going to happen. We don't know what form it's going to be in. We do not know what how they're going to roll it out to each of the states. But as it said in the proposed rule, it would be all 50 states starting January of 2022. It is being hailed by some to be the best thing since sliced bread, and by others, end of times. Cindy, where are you with value-based purchasing at this point?
Well, I am where I tend to be, Sherry, which is middle of the road. The extremes concern me because the idea that this is just going to be all hearts and flowers and wonderful is a little bit unrealistic. Maybe I'm a little jaded as long as I've been in home care. But the disturbing one to me is it's basically catastrophic or it's going to upend everything. I see lots of, oh my gosh, how are we going to prepare? Once again, almost like we're going into combat. So I decided to spend some time in the report, the summary report that came out recently about the first 4 years of the demonstration project, essentially. And also, in full disclosure, I was part of the technical expert panel, the original one, with respect to value-based purchasing in home health. So, I'm hearing all these things and what are we going to do? And I've been to a couple presentations and it's been very much kind of the nuts and bolts and what you have to focus on and what are going to be measured and total composites. And I think all of that is important. As organizations, we need to make sure we understand the mechanics. But what's striking me is the bigger picture that comes out of the report because the whole purpose of value-based purchasing, at least as it's been consistently portrayed, is about quality and efficiency of home health services. Okay, so we look at that and say, all right, that means it's about our work as an agency. We need to be focused on quality. We need to be focused on being efficient in getting to those outcomes. But then as you start to look at the outcomes that they're looking at, I go, wait a minute, there's really nothing new here. I'd say the new thing is taking function and putting it into composites, something that I was part of multiple conversations about how do you really show true change in function? Is it really just, one item in isolation, or is it really putting things together, which facilitated the mobility composite and the self-care composite? But again, these are things that have either been a focus area for us from an Oasis perspective for payment in PDGM, for home health compare of the past, of the current, of the stars, of everything else. So I look at it and say, wait a minute. So if we are focused on these quality measures to the best of our ability right now, then what is the panic button issue? I think what stood out to me in that report, although it talks about the focus being our quality and efficiency, the findings, the biggest finding being put out there is, yay, this was so successful, was about money saved by the Medicare program. And when they looked at money saved, they looked at the time the patient was in home health plus the 30 days after. And the big savings, Sherry, came from reduced use of hospitals, reduced use of skilled nursing facilities. So it's like, okay, so you saved over $600 million in 4 years to the Medicare program in these 9 states compared to the other 41, overwhelmingly by reducing other services. Because what they said was there was no net effect to the Medicare home health payment. So the money going to home health was basically no different in these 9 versus the 41. But the big takeaway was look at all this money we saved because they didn't use other resources. And then you say, well, wasn't this about our quality? Yeah, there was a little bit of a change in quality. There was a little bit better in performance in some measures from a home health perspective. Interestingly enough, there was also a slight drop in these 9 agencies with respect to some of the patient satisfaction measures. So you go, wait a minute. So this was supposed to be about our quality. Yes, there was a little bit better quality in these 9. There was a little less patient satisfaction. There was more use of ED. But the big win was you kept them out of the hospital, you kept them out of skilled nursing facilities. So if the report that appears to be the leverage that's going to drive expansion is about keeping them out of higher cost care, then why are we approaching value-based purchasing from a preparatory standpoint, looking only inward at our outcomes, at the measure, at the composite. Yeah, I need to know that, but the bigger issue is how am I keeping them out of the hospital and how am I keeping them out of skilled nursing facilities?
Cindy, am I right in assuming that the only measure they're looking at to get this is the Oasis, the start of care and discharge Oasis, or the start of care recert and discharge Oasis? This is where they're getting their data from?
They're getting some of it, Sherry.
Okay.
A lot of it is coming from claims data, and that was very interesting. Obviously, being on the technical expert panel, you're not supposed to say all kinds of secret sauce stuff. But I can tell you this, that when they started looking at the data, the first thing that stood out was look at all this improvement in function. Now, the other items that are part of this calculation, and the model has been refined over the first few years in that project, but initially the ones that were related to claims weren't changing. The claims data items weren't any different substantially in the 9 compared to the 41, but the functional ones jumped first. And I remember sitting there thinking, oh no, oh no, no, no. I'm not sure that this is everybody's gotten better at treating function. Once again, the one thing an agency can control in terms of choosing Oasis responses is the one that started to look suddenly better, the quickest of them all. And it's like, is that truly higher quality care in these 9? Or is it once again looking at Oasis responses and picking answers that facilitate the appearance of more improvement? We can kind of see that echoed again in the proposed rule when it came out and said that the functional impairment that was predicted in the low, medium, high categories came out different and slanted to the high once PDGM was implemented. So you kind of look at that and say, is that really? Because if agencies were doing so much better at managing function in these 9, why did that early data indicate they were still going to the hospital and the ED at the same rates as the other 41?
I'm jaded. I will admit that to our audience. I am completely jaded because I remember when we first went to outcomes as being a measure that was reported on Home Health Compare, albeit old data back in the analog days. Those of you that are IT folks, you're probably winced when I said analog days. Back in the analog days when they started measuring outcomes, I always used to get a little butt hurt over the hospitalization one. And the reason I got butt hurt, and that's a Southern word, butt hurt, by the way, Cindy. The reason I got butthurt is because as an agency owner, I had little to no control over whether the doctor told him to go to the hospital. Do you remember those days? If
Oh yeah.
you called the doctor's office, they said call 911. They did not want anything to do with it, send them to the hospital. And so as an agency, we were trying to educate our providers, but at the same time, we knew people, all of us knew people in the industry that would not transfer a patient to home health. They would discharge them to home health or to, excuse me, discharge them to the hospital. They never transferred them to the hospital. They would discharge them to the hospital and then
Correct.
readmit them again. And that would decrease their quote unquote hospitalizations because they decrease their transfers to the hospital. Doesn't this stuff still have that as a gaming option?
I think they've tried to minimize it as much as possible, Sherry,
Okay.
because when they're looking at this information about hospitalization and SNF use, if you think about it, we don't have clear items specific to skilled nursing facility use directly in the Oasis. So I think they've kind of understood the gaming risk, and that's why so many of these measures have moved to claims.
Got it.
Not the issue of maybe I discharged them thinking that fixed it in the short term on my agency data, but the claim is still going to show that 10 days after you discharge them, because remember it's the 30 days post, now they
Mm-hmm.
ended up in the hospital.
Okay.
So being able to look at that big picture, they've tried to minimize those things. And that's why, the functional element, there really isn't a claims-based anything that really works to measure function. And as therapists, I think, yay, somebody still cares about function. Clearly Medicare does. There's so much discussion even in the post-acute cross-setting measures about function and how do we measure function. And function is so important for keeping this population of individual out of higher cost care. I'm glad it's still there, but it remains the only part that's Oasis driven because they keep chipping away at those ones that give more of an opportunity for us to massage the data a little bit.
Mhm.
And I think, but the other piece to me that stands out is sometimes when we look at preparation or dealing with outcomes in general, it immediately goes to the Oasis. And we've got to make sure that thing is right. And I absolutely agree. Okay. But we have to make sure right is synonymous with defensible, because you and I have done many, many reviews of the Oasis document and coding. And there's times where, yeah, this looks like a great case mix score. And yes, this organization has really good outcomes. But as you look at the Oasis, you say, yep, there's the answers that get that. And then you look at the assessment written by that same clinician, and this doesn't line up.
Mhm.
This does not fit with that. So we already know the suspicion exists in the universe from CMS anyway, but now the term upcoding gets kicked around. Or we have this, yes, everything is getting so much better, but then you look at the visits provided by the clinician. And one of my favorite, Sherry, is that bathing is identified as an issue at the start of care. OT is ordered. Yay! Not a single OT visit worked on bathing, not even once.
Wow.
Not even once. It's just doing arm exercises and whatever else. And then suddenly at discharge, they can bathe better.
Mm.
Now, the documentation doesn't indicate anybody. There was never a home health aide. Nobody did a shower once during this episode of care, and yet somehow it's better at the end. This is where I think clinicians need to step that game up about what their role is in outcomes, because the Oasis does only one thing. It measures stuff, okay? It just measures things. Outcomes happen in between the two measurement points. When clinicians look at patient-specific issues, create care plans, and execute care plans to figure out why this individual can't bathe, how are we going to work on that? What are we trying to get to in terms of the desired outcome? And what concerns me is when that doesn't appear front and center in the middle, it just fuels the idea that this is gaming, that we're able to show improvement just by answers being picked a certain way, as opposed to, are we really embracing the whole purpose, at least the intention of outcome measures, which is to focus our care delivery, not just to become obsessive compulsive about Oasis answers.
I agree, and the fact that they've gone to claim data is extremely interesting in this whole model. I know that some of the biggest proponents, and we're getting on. This is going to be a longer podcast than we normally have to our audience. When we're talking about value-based purchasing, the biggest proponents, the ones who want this and think that it's the best thing since sliced bread, tend to be the larger providers. Have you seen that, Cindy?
Sometimes it's hard to tell if that is a trend in terms of agency size, or those are the ones that the person creating the article or the material reached out to.
Yeah.
But I think that the larger ones have a bit more flexibility, as it were, in terms of they tend to have specific resources dedicated to individuals whose job it is to make sure that the final Oasis is accurate and clean and ready to go. They tend to have internal educational resources that can work with clinicians about outcomes and those types of things. I think it's the medium size to small size where you well know from your past, Sherry, that nobody's wearing one hat. Everybody's trying to wear three or four. So now I'm trying to review Oasis. I'm trying to get the scheduling done. I'm trying to hire people. I'm trying to manage patient concerns. I have to deal with all these other things. And maybe that ability to focus this um, is more difficult, but I think that tends to overwhelm the medium to small to say we're doomed in value-based purchasing. When the reality is the same strategies, you don't need all that extra stuff. You need to have the focus. You need to
Mm-hmm.
be having the clinician engaged in, how do I make sure that the answer you select from the beginning is correct, so that we don't have to deal with going back and forth on this stuff and you understand. And as we plan care as an interdisciplinary team, what issues did we identify utilizing the Oasis, and how are we going to divide and conquer and work on those? I mean, I'm not trying to oversimplify it, Sherry, but I think sometimes it's gotten overcomplicated, which then freaks people out even more when you start saying some agencies are going to get a bit more money and other agencies are not.
Absolutely. And again, I have a jaded perspective having been an agency owner and having been one of those small agencies, and you're kind of caught up in the as a dolphin in the tuna net, so to speak. You're caught up with the wave that has occurred, or the wake that has occurred, that happens from the larger agencies and their practices. And oftentimes it doesn't feel realistic when you're a small agency to see positive outcomes on 90% of your cases. Just does not feel realistic when you have folks that are sicker and sicker coming home. But on the flip side, let's go back to hospitalizations real quick, because that's interesting. The claims data, they're looking at whether or not they go to those higher cost center of cares, or higher center cost. Yeah, one of those
I know what you mean.
phrases. Okay. The hospitals had this happen to them a couple years ago, where they were getting dinged on their reimbursement for rehospitalizations based on the same diagnosis coming back into the hospital. We saw an interesting phenomenon that sprang up out of that, and it's called, you ready? People are going to wince when I say this, quote unquote, observation status. You can't
Well,
get dinged on a rehospitalization that never occurs, meaning that the hospitals were placing people in observation versus admitting them back to the hospital. So that was sort of a workaround to that ding that the hospitals were receiving when they were coming back in the door. Do you think there's any risk for that with value-based purchasing going countrywide potentially in
oh, you're
2022?
paying attention to that, Sherry, because if in the summary report, so yes, it was over 600 million saved by reducing use of inpatient hospitals and skilled nursing facility. However, there was a over $65 million increase in spending in those 9 states in those 4 years in
Wow.
2 areas: outpatient EDUs and observation statement spending. They called it out in the report. So I'm glad as a home health provider that they didn't ignore that piece. So they parsed it out to say our big savings were there were less hospitalizations, less skilled nursing facility uses during the home health episode and 30 days after. However, there was an increase in outpatient EDUs and observation stay spending. So you say, thank you for paying attention to that. It fuels the discussion about how can you be in the hospital for 4 days and technically never admitted? I mean, that doesn't seem like that's how observation was supposed to work, but they did see an uptick in those 9 states because of those 2 areas. But it offset, I mean, that was 65 million against, almost, nearly 10 times as much total savings. But they did note in the report that cost for those two went up.
I think when we had our agency, our longest quote unquote observation stay, which was in a hospital room, just like somebody who was admitted, was like 16 days of observation status. And that's was so frustrating back then because you didn't know if they were admitted or not. So you did all that Oasis paperwork with a transfer and resumption, all that stuff that you didn't necessarily have to do. Some of that I think has been worked out. But it's still, I hate to be the naysayer, but I overall, I'm eyes wide open going into this. And one of our taglines for Canadian Craft, our biggest tagline is, "We are your revenue protection experts." We can implore you, and Cindy, I'm going to give you the last statement, to implore these agencies to make sure that the data they're giving to the federal government, to CMS, is accurate. Because when they come back and they check out things, I'm going to let you make the last statement.
Yes, again, as we said a moment ago, accurate and highest paying are not really synonymous. We have to make sure that the responses in there are defensible. And that means some patients are not going to end up in the highest functional category. They're not going to end up with a primary diagnosis that puts them in the highest paying group. We have to demonstrate consistency and commitment to making sure those responses are correct. But again, to the value-based purchasing piece to this, I can have, correct start of care responses, but if the care delivery after that doesn't focus on the patient specific reasons they're having trouble with function or they're having challenges with their disease management, then I can cross all my fingers and toes. I'm not going to do as well in value-based purchasing. I need to have that focus with the bigger eye, as we started with, toward even for patients that I can't improve them, that I maybe utilize maintenance therapy and my outcomes don't look that much better for them in the end. Check yourself and say, Did we keep them out of the hospital? Did I give them strategies that for the next 30 days after we're gone, I don't expect them to end up in a nursing home or in the hospital? Because if you look at that being the cornerstone of why they believe this program worked and why they want to keep going, it was those two things. So let's not lose track of that in this, I got to get my outcomes going. Yeah, for some patients, they're not going to get better. But did you achieve the bigger ticket item in the eyes of CMS and in our hearts as well? Keep them out of the hospital, keep them out of the skilled nursing facility.
Boom. Drop the mic and walk away. You guys count on us for some real talk, and stay tuned and subscribe to our YouTube channel for free education and real talk podcasting. So if that's it for you, Sydney, we're going to let this one be done. And I'm sure something tells me we're going to be revisiting this topic as we get closer to 2022 when the final rule comes out. I just have a feeling.
Yeah. I think so. Have a good day.
All right. Thank you.